Good morning, everyone. I'm Peter Stanton, publisher of the Worcester Business Journal, and on behalf of the WBJ and our sponsors, welcome to our annual Healthcare Forum. Every year we survey our business audience about what keeps them up at night, and invariably the cost of healthcare is always near the top of that list. So we're here today to talk about the healthcare industry in our region, in the state, and beyond, and dig into what kind of progress we're making in containing costs and harnessing the many technological advances and innovations to deliver higher quality care to more people. The healthcare sector employs more people than any other industry in central Massachusetts, and the progress our institutions are making not only has a direct effect on us as individuals, but also on the region's economy. So we've got a terrific, as you know, we've got a terrific set of speakers with us here this morning, and I know we're all looking forward to hear from them, so we'll move right into the program. I just want to note this annual forum is only made possible by with the support of our sponsors, so I'd like to thank them all for their engagement and investment in promoting this important healthcare conversation. And those presenting sponsors are Fallon Health, Reliant Medical Group, and UMass Memorial Healthcare. Our corporate sponsor is National Grid, and our exhibitors are the Language Bank, a member of a Century Care Alliance, Massachusetts Health Connector, and Pfizer Vaccines. And so I would like each of our presenting sponsors to come up and share a few comments. And I'd first like to call up Dave Presict, who's the Senior VP and Chief Sales Officer at Fallon Health. David.
Good morning. Fallon Health is pleased to sponsor the Worcester Business Journal's annual Healthcare Forum. Certainly thank you, Peter, and his staff for putting on this opportunity to discuss important healthcare topics that impact all of us. Throughout our 41-year history, along with our provider partners, many of whom are in this room today, Fallon's been working to improve the quality of care for members and find innovative ways to help contain costs. We've always believed that key stakeholders must work together to find better solutions. So today we'll be discussing and learning about healthcare innovations and their influence on the cost of care. It's always been an important conversation, probably perhaps a little bit more important today, as Peter mentioned. The Associated Industries of Massachusetts recently put out a survey. 74% of the business surveyed identified health insurance as their #1 business concern. So we definitely have some work to do. And progress is being made, both on innovation and cost containment. One example of this is the Mass Health Accountable Care Organization program, which the state introduced earlier this year, which is the redesign of the state's Medicaid system. For those of you that don't know, the state's Medicaid system is roughly 40% of the state's budget and covers 1 in 4 residents in the Commonwealth. So the goal of the ACO plans is to reduce costs, provide coordinated high-quality care that ensures people receive the right care, the right place, at the right time. Fallon is proud to be part of this effort. We are actively engaged in 3 ACOs, 1 in Berkshire County, 1 in the Merrimack Valley, and 1 in Central Mass. Our partnership with Reliant Medical Group is here in Central Mass. And although we're not quite into it a year, early indications are that it is working. And we believe it's due to the collaborative approach of delivering a whole person care that addresses not only the needs of the medical needs of the patient, but their behavioral health and social needs. So I'm sure we'll hear more about ideas that will help move our system forward. And certainly thank you to the Worcester Business Journal again for this opportunity. And thank you to the panelists and our speaker. So thank you, Peter.
And please welcome up Linda Cocola, the Chief Communications and Administrative Officer at Reliant Medical Group. Linda.
Well, I have to say it is just thrilling to see how crowded this room is, which I think is really a testament to how important this topic is. I want to thank the Worcester Business Journal for once again presenting this forum. I think you've really been leaders in, promoting the healthcare conversation. And as sponsors, and I think we've been sponsoring this maybe even since the beginning, we're really thrilled to be facilitators of this discussion. I want to also thank the other sponsors, UMass and Fallon and National Grid, because I think this is a problem. The rising cost of healthcare is a problem that we together have to solve. So I think it's terrific that there's so many stakeholders in the audience. At Reliant Medical Group, I can tell you that we do stay up at night worrying about the cost of care. I think it's one of the biggest challenges before us. Quality care, providing high quality care that meets or exceeds national standards is a given for us. It's what we've always done. But we really do think about the cost of care. We do see ourselves as obligated to be responsible stewards of medical resources. So this topic is near and dear to our hearts. It's a timely topic. It's a necessary topic. And I'm really thrilled that we're all going to be here today to exchange ideas and do some problem solving, because I think that's where we are at this point with this particular topic. So thank you so much and look forward to the conversation.
And Lori Albert, Marketing and Communications Manager from UMass Memorial Healthcare. Lori, there she is.
Good morning, everyone. This is my first time here, so this is really exciting. Hello. Excuse me. My name is Lori Albert. I'm a Marketing and Communications Account Manager at UMass Memorial Healthcare. We're pleased to be a sponsor of today's event, and a big thank you to the Worcester Business Journal publishing team and events team and Chris for coordinating today as well. It's always a big undertaking, so thank you. It's very much appreciated. UMass Memorial Healthcare, as many of you know, is the region's largest healthcare provider and employer. We are committed to offering exceptional, high-quality, low-cost healthcare to the population we serve. Our organization strives to offer innovative treatments and models to access affordable healthcare, and we do this successfully with other organizations that hold the same beliefs. A couple of our more recent partnerships include our affiliation with Carewell Urgent Care, which we now have 5 locations in the region, which offers convenient, accessible, low-cost healthcare to the community, as well as our newest partnership or collaboration with Shields MRI and fellow sponsor Reliant Medical Group. We have a new surgery center, or ambulatory surgery center in Shrewsbury, which opened this past summer, which has been very successful, and it's a great new, modern, convenient, low-cost surgical center for many outpatient day surgeries. So we're very proud of that new partnership that we have. And hi, Linda, nice to meet you. We've recently also launched online appointment scheduling, which is really exciting for us with our new implementation of Epic. We're now able to offer online appointment scheduling for both new patients without a referral as well as existing patients. We do this for primary care, most of our primary care providers, as well as a growing list of specialties. So that's really exciting. People can now schedule appointment 24/7, when and where they need to do it, and find the provider and time that meets their schedule and location. And finally, and why we are here today, is to discuss UMass Memorial's outstanding achievement in the Centers for Medicare and Medicaid Services, the Medicare Shared Savings Program, ACO. You will hear from John Greenwood, who is our president of the UMass Memorial Accountable Care Organization and senior vice president of population health for UMass Memorial Healthcare. John will discuss how the UMass Memorial Medicare ACO ranked first in New England and 15th nationally by providing quality and personalized innovative care, which is a real huge honor. Congratulations. And with that, we look forward to participating in today's forum, and thank you again to the Worcester Business Journal for having us, and hoping together we can all work to continue to offer accessible, low-cost healthcare to our community. Thank you.
Thank you, Lori. So it's my pleasure to be able to introduce our keynote speaker, Dr. Soma Stout. Oh, there she is. Dr. Stout is currently serves as Vice President at the Boston-based Institute for Healthcare Improvement, the IHI. She's the executive lead on their 100 Million Healthier Lives program, a worldwide initiative across 28 countries with the goal of achieving transformation in health, well-being, and equity for 100 million people by 2020. That deadline's coming up. I hope you do. She's also serves as the co-principal innovator for the organization's SCALE initiative, which supports communities around the country to accelerate their journey towards a culture of health. Prior to joining IHI, Dr. Stout served as VP for patient-centered medical home development at the Cambridge Health Alliance, where she led a number of initiatives that achieved breakthrough results in health outcomes and costs for a safety net population. While at CHA, she also founded 2 family health centers that continue to serve as national models for community-integrated primary care. And in 2012, she was named a Robert Wood Johnson Foundation Young Leader for her contributions to improving the health of the nation. And the list goes on. It is clear that Soma Stout continues to grow her circle of influence, and we're thrilled to have her here with us this morning for the keynote address. Please welcome Dr. Soma Stout.
Thank you so much. Thank you so much, Peter, for having me here today. I'm here in part because we are getting close to that deadline and we need your help. But really, I'm here because I'm from Massachusetts. I spent the first, 20 years of my career practicing pretty locally right here and down the street at Cambridge Health Alliance, which may not seem down the street, but the traffic is really good out here. But at Cambridge Health Alliance, I started as a primary care doctor and a medical director of a community health center, taking care of people half of whom spoke a language other than English, all across my clinical practice as both an internist and a pediatrician. Got to see 3 generations of a family often under my care. Went on and was a medical director there, and eventually ended up becoming a vice president that as we became an early adopter of payment reform at Cambridge Health Alliance and decided proactively to shift our business model to go from fee-for-service to global payments within 5 years. We went from literally 0 to 60 in 5 years. Became the vice president leading the transformation system-wide. And the story that I'm about to share with you comes from what did we realize were the hidden places where we could make breakthroughs as we were able to achieve within 2.5 years an improvement in health outcomes in our transformation sites for a safety net population above the national 90th percentile while taking 10% of absolute medical cost out of the system and improving joy and work for the workforce. As we did that, we realized we had several aha moments about what we needed to do differently. And almost all of them were not about working harder, they were about working smarter. And so that's really what I invite us to think about. It's what led me to come over to IHI to lead 100 million healthier lives, because we realized actually so much of what we need to do isn't just to do medicine more and harder and faster. It's actually to be able to do more fundamental things like seeing the whole person and seeing the whole system and creating bridges where people are falling through the gaps. So with that, how many of you have heard of the triple aim? So the IHI has been on a journey to achieve the triple aim for the last 10 years now, actually more than 10 years. And as we've worked with hundreds of communities, the same trends that we saw at Cambridge Health Alliance of what was happening have emerged all across the country and all across the world. It's what led us at IHI to launch 100 million healthier lives, because what we realized is, as we said, we need to improve the health of populations, the experience of care, and reduce the cost of health care. What people typically did to improve the health of populations was they did the things that they had access to within their walls. The reality is healthcare didn't have good relationships with public health or with social sector and human sector agencies. And so it's hard to improve the health of populations if you actually don't know who you can partner with in order to be able to do that. So as we began, we realized if we really want to achieve the triple aim, we need to actually rethink how we achieve the triple aim, not just to ask healthcare to do it sort of harder and faster within its walls, but invite us into a whole different journey. This is the first place where I had an aha. I had the privilege, one of the things we did right in the Cambridge Health Alliance transformation is that we asked patients to be part of every redesign team. We said, well, there's no such thing as patient-centered redesign, which doesn't have a patient actually actively contributing to the ideas. And one of them, a mother of a child with a special healthcare need, Kristen Lynn, drew this picture for me one day. She said, Shoma, I just want you to understand, this is my son Gabe, and Gabe has a neurodevelopmental disorder. And this is our family, and here is our pediatric practice where I'm serving as a patient partner in the improvement team. Things are getting better here because of this redesign. We have better access now. We can get through the phones. We can schedule our own appointments. things are even getting better in terms of coordination. We now have all these ways where people across the specialty care, specialists and PCPs, are beginning to talk with one another. But I just want you to understand, like, this is my world. Everything in blue here are all the people involved in healthcare who are taking care of Gabe. And somewhere along the way, people have forgotten things like she said, Gabe got potty trained at the age of 8, a little bit later than usual. And no one remembers anymore who ordered the diapers. And they just come month after month. And I have a garage full of diapers that I'd really like to have my garage back. But she said, that's not really the big thing that I'm concerned about. So see, here's everybody in the education system who's trying to help Gabe graduate from school and have a job someday. It turns out whether you graduate from school, from high school, is the most important long-term predictor of your health outcomes. Do you know that? So all of us should be in the education business if we want to manage chronic disease successfully in the long run. But what she said was, I'd love for the people in the schools and the people in the healthcare to actually once a year coordinate to create a health plan that's about supporting Gabe to thrive. What I really want, she said, is for them to have each other in speed dial. She said, everybody over here, all the other people in our lives that is invisible to any system that is helping us, our family, to make it. These are other families who have kids who have special needs. These are like our legal and financial planning, and you may not think that matters, she said, but I've had to quit my job to manage all of this. And that's meant our family income has gone down by half. I don't know if you know this, but medical bankruptcy is 50% of bankruptcies now in the US. 50%. And so when someone with a special health care need, and this is a upper middle class family, this is not a family in poverty. What she said was, if no one ever even sees or understands all of the impact of what's happening here, and I don't know about you, this was the first time I understood that the social determinants of health weren't just a set of services that we provide for poor people. It's actually about how everybody achieves health. And when you look at this picture, it was the first time I realized not only how much more there was to coordinate than we had initially imagined, but also how many assets were being left at the table that we were never leveraging on our way to improve health and well-being. And for us, it changed how we came to approach the design of healthcare. We said, when something isn't going well, when someone's health outcomes don't seem to be going well, take a visit offline, stop and have a conversation which begins with what's going on in your life. What are your goals that you're trying to achieve? And what do you think we could do to help you to get there? What are the barriers you're facing? And then the rest of it was frankly building the systems that made it possible for us to support people in their goals. And as we did that, we watched hospitalizations decline by 50%, 75% in a wide range of conditions. It was about actually getting back to the fundamentals of seeing the whole person. This is one of those cases where we were really successful. We really provided like a high-functioning team-based primary care for patients with, all patients with diabetes. And we saw a 36% reduction in hospitalizations as a result of that. See that nice blue line? That's good, right? And it sustained itself over time, and it's now, I think it's past 40%. The problem is that red line. See that nice little red line that's going up by almost threefold? That was a number of people who developed prediabetes and diabetes in our population at the same time. Now, this is not based on a redefinition of diabetes. This is based on A1C levels, so it's pretty hard data, and it's consistent across time. A third of it is because of healthcare reform in Massachusetts, where we got more patients. But that doesn't explain a near threefold increase. The reality is that as I began to look into, like, why is it? Of course, some of it is the context of our communities. If people don't have access to safe, healthy fruits and vegetables, if they can't afford them, it's hard for them to eat healthily, right? But it turns out that it's more than that. And you know, Cambridge Health Alliance wasn't alone in that. This is the American Diabetes Association. We're spending about, 1 in 3 people have prediabetes or diabetes now. That's expected to get toward 1 in 2. We spend $322 billion a year right now taking care of people with prediabetes and diabetes. What do you think it'll be by 2020? Any idea what it's projected to be? Take a guess. I'm sorry? 25% more, okay? So about 400 billion, you'd say. Anybody else? $520 billion, $200 billion that will just walk out our doors, even as we're trying to achieve the triple aim, because we continue to be winning the worldwide race to be the most obese country in the world. And it's more than that. There's this pipeline of disease creation of population health that's happening right before our eyes that we can try to mitigate after the fact, right? As we try to, and we should, of course, after people have prediabetes or diabetes, do everything in our human power to help them manage that illness well, right? People should get the care they need. But the reality is, if we can't get ahead of the problem of what leads to prevention in these numbers, we're not going to make it. And even this is like the best possible care. Our care system was noted by Health and Human Services nationally as one of 4 innovative and effective transformations in the country. Even with best of everything we can do, we can't get there if we only think within our walls and don't think differently about what it would take to turn off the pipeline. What I always say is, and you have to remember, someone spends 5,000 hours at home managing their chronic disease for the 4 15-minute visits that they might come to see a doctor in a year. And that's 4 is a lot. For most people, it's 1 or 2. And until we can get ahead of that, what's happening in those 5,000 hours, and partner with the people that they're seeing much more often, like their employer, for 8 hours a day versus for an hour a year for us, we can't keep flogging that hour for we need to make the best advantage of that hour, but we can't expect that hour to do everything for us. Does that make sense? But if we think differently about where health can be created and who can be creators of health, we can get there to some very different answers. It turns out that the story is a little bit more complicated than simply where people are getting health, which is not just in the healthcare system, but actually needs to be in the whole community. I hope you have another power source over there. It turns out that exposure to toxic stress may lead to as much as a 40-fold increase in people developing prediabetes and diabetes by the time they're 50. So everything we do, everything I could do as a primary care doctor might improve their outcomes by twofold. This is 40-fold. If we think just within our walls, it's like the bucket brigade trying to put out a fire while there's a tanker full of gasoline going into the fire at the same time. And here's how we know this. If you look at these maps, how many people think these maps look pretty similar to one another? Raise your hand if it looks pretty similar to you. Not identical, but pretty similar, right? So this is a hotspot map where darker is worse, right? So in this case, the dark areas are maps of economic hardship in Los Angeles County. The right-hand side is maps of childhood obesity in Los Angeles County. And those maps look identical to one another. And it turns out that when you're growing up in an environment of chronic stress, you end up with a much higher risk of diabetes. And now we even know some of the biochemical pathways. You have chronic stress, leads you to get flooded in insulin, that leads you to insulin resistance, that gives you premature development of diabetes. We're growing the chronic disease epidemic of the future and then trying to treat it after the fact. But it's like medicating poverty, you know? Like, it's not the most strategic way to address that. And if you look at why, it turns out these maps, if I were to do them here in Worcester, would probably look the same. They've been replicated all over the country. And it starts here with childhood obesity, but if I fast forward a few years and showed you a map of diabetes levels, it would look exactly the same. And then if I showed you premature death of people dying at the ages of 50s and 60s while they're still in the workforce, it would look exactly the same. And so what that ultimately translates to is that these 2 kids, I don't know if anybody see this story in it was I think in the Cleveland Journal or something. These 2 little boys who, you know, I'll call one Sean and one Thomas, they went to a barber shop one day, got their parents to take them and had their head shaved. They were kindergartners and best friends, and they decided that they could trick their teacher into believing that they were interchangeable. I say it's one of those documented cases of, that tell us that racism is an acquired disease, right? But in reality, these two boys, depending on where they grow up, they might be born in the same hospital, grow up just 2 miles apart, and have a 25-year gap in their life expectancy. That's determined almost from birth, because one will grow up in a neighborhood that looks dark brown, and one will grow up in a neighborhood that has not just much more access to opportunities, but many more access to second chances, many more pathways and peer supports and systems that lead to different outcomes, all the way to a 25-year gap in life expectancy, just 2.5 miles apart. It turns out this isn't accidental, that this is in place. At IHI, we say every system is perfectly designed to achieve the results that it gets. And in reality, we have a system in place that began with a legacy of structural racism that we've had in place for decades, that we just have to acknowledge and then actually do something about if we don't want to be the recipients who are asked to Medicaid poverty after the fact. There's a reason that we have place-based differences. It's because there was a history decades ago of redlining where people literally said that communities of color were risky places. And if you had more people of color living in a place, they drew red lines around them and said, these are going to be high-risk places and we won't give people loans to actually buy property there. And that meant businesses didn't invest in those places, that they had fewer jobs. With fewer jobs came less of a tax base. With less of a tax base, there's less money to invest in the schools, the parks. Do you get the picture? And then you get what is over time generational accumulation of poverty and the social determinants issues. And you might say, why is she talking to me about this? What could we possibly do? The thing is, turns out there's a lot that we can do, but we have to think differently and a little bit more strategically than we're currently doing. And we need to absolutely maximize what we're doing in care delivery, but we also need to think about what else we do that's different. Our colleague from UMass said we're the largest employer in this area. What would it look like to change employment practices, for instance, to intentionally do, as many systems are doing, to look at what it would look like to hire and build cradle-to-career pipelines from communities of concentrated poverty, thereby transforming legacies of redlining to ones of greenlining. It requires us to think differently and with creativity. But the first thing I want to invite you to consider is that the health and well-being of people, of places, and the systems of society are actually interconnected, that we can't solve this problem without it. I didn't start out thinking that's where my life was gonna go. I thought I was just trying to figure out how we improve health outcomes. But it turns out that if there's a tanker full of gasoline, while we're a nice bucket brigade bringing water to the fire, we can't really win if we can't figure out how to turn off the tanker. Does that make sense? 5 key shifts that we say we need to make. 1, we need to shift from a sick care system that's the job of healthcare alone to a health and well-being system that's all of our responsibility. And that means we need to make new friends. We need to make friends with schools and businesses, places where people are for 8 to 10 hours of their lives, and invite them to be partners in creating health. We need to take this work on equity from doing good to a recognition that we're interconnected, that we actually can't afford the price of poverty in terms of either poor health outcomes or a cost or historic inequity. We need to shift in our thinking from pathology to vision. So real change is possible, and a lot of what we've done in 100 Million Lives is figure out the strategies to take action that achieve far better results. We're already at well over 20 million lives improved, and with help, we expect to get to, we're hoping, about 105 million lives improved, but it really needs all of you, needs all of us to be able to think differently. We need to shift our thinking from people in communities of poverty to people in communities of solutions. You know, Peter was telling me this morning that actually immigrants are entrepreneurial because they've had to give everything up and start a huge new venture of going to a new country. People in poverty aren't people who are simply sitting there waiting for things to happen. They're enormously resourceful as a single mother tries to make 2 jobs work to take care of her family and her kids. How do we actually see that, in fact, they're places of trapped, which means they're structural barriers that prevent people from reaching their outcomes, and untapped potential that we haven't expected a lot, and therefore we haven't even invited them to the table half the time to help define the solutions. And finally, we need to shift our thinking from scarcity to abundance. Kristen's map was filled with abundance. There were a lot of resources there, but we weren't well coordinated. What does it look like to get there and to think in a different way? So 100 million is a call to action to be an unprecedented collaboration of change agents who are pursuing a result that's so big that we know none of us could achieve it alone. It's intentionally big because it forces us to think differently and to act differently. And our vision is to fundamentally transform the way we think and act to create health, well-being, and equity. And one of the things we did was make working on equity the price of admission. Over 1,850 members, reaching over 500 million people now as a network. I always tell people it's really simple. You just need to improve the lives of 1 in 5 people in front of you. That's not that hard, right? That's not that hard. Come on, 1 in 5. We ought to be able to do that. Especially if we begin to think differently. Because as I told you already at Cambridge Health Alliance, we started getting the outcomes when we stopped thinking narrowly about what people needed and started more broadly asking them questions about what would help. Unprecedented collaboration, innovative improvement, and system transformation are the sort of pillars of 100 million. And in order to do that, we've focused on 6 core strategies: creating healthy, equitable communities, building bridges across sectors, creating a healthcare system that's good at health and good at care, including prevention, promoting peer-to-peer approaches, recognizing that actually people have a lot to offer to one another about what helps them to be healthy, creating enabling conditions, and developing new mindsets. So one of those unprecedented collaborations, we said, well, what if we could bring many of the groups that are trying to work with healthcare and healthcare organizations to come up with, well, what should healthcare, knowing what we know now, what should healthcare do in the space of population health? And I'd love to share with you some of what has come up of a process that's engaged well over 100 healthcare organizations and some major partner groups, and a framework that's sponsored by, co-sponsored by the American Hospital Association, the Institute for Healthcare Improvement, Stakeholder Health, ENRI, and 30 other pioneer sponsors. Where we said, well, the first thing we need to do is create an aligned messaging to the field. Like, if we're all telling people different things, it's going to be super confusing for people. So let's get together and not have things that are a smidgen apart in terms of what we think population health is, for instance. And then let's build a pathway of support and engage people to be on this journey together. So the Pathways to Population Health framework came out of that, and it basically has 3 things. One, it has a framework, a compass. It connects people for a compass where you can assess where you are and take action, has an oasis of resources, and then there's a support system. But it basically goes through to 2 things. One, it says, it gets language right. It says, what's population management? Population management is improving the health and well-being of your patients or the people you directly reach. Population health includes improving the health and well-being of the places and addressing equity. You can't really say you're doing population health unless you're doing both. But it says more than that. It says that there are some foundational concepts that we all are going to say we agree on. We're not going to debate these things. We're going to instead focus on how we take action. The first is that health and well-being develop over a lifetime. The second is that social determinants drive health outcomes over a lifetime. And third, that place is a determinant of health, well-being, and equity. And then if the first 3 are about, what creates health, then the second 3 are about, well, how can health systems respond? What we said is that the health system needs to address the key demographic shifts of our time, like the rise in chronic disease that's happening, or the aging population. The 5th is that the health system can embrace both innovative new payment models, but also use its existing assets toward far greater value to society and to solve this problem. And the 6th is that we're not in this alone. This isn't about healthcare solving all of this. It's about, we recognize we only hold a piece of the puzzle. And what we need to often do is look at where in the community people are already working to solve this, draw up a chair at the table, and ask, what could we do to help using the assets that we have before us? So as we frame that out into what that means, we said it means that healthcare has two jobs to do. One is to improve the health and well-being of the people before us that are our patients or employees. And second is to improve the health and well-being of the places in which most of those patients are coming from. Does that make sense? The communities that we relate to. And the third is to improve the systems of society. Remember, people, places, and systems of society. Just bear with me for a moment as we go through this. So what we realized as we looked at bright spots is that actually as people began doing these two things together, they could get much better faster. And that this whole group of what improved population health is includes all four of these domains. We then broke it up into 4 portfolios for action. The first portfolio is, everything on this left-hand side is improving the health and well-being of people, all right? And what we said, we kept it simple, we said portfolio 1, you need to improve the mental and physical health. And you need to improve that together. These are not separate things. Portfolio 2, you need to improve social and or spiritual well-being, right? And that means like asking people what's going on in their life. Spiritual is not necessarily whether they're connected to a church, that might be part of what their spirituality, but it's really having a sense of purpose and meaning in life. It turns out that if you're socially isolated, that's worse for you than smoking. It turns out that if you don't have a sense of purpose in your life, that's pretty devastating in terms of your health outcomes too. And so it's services like housing and transportation, but it's also people's sense of belonging and connection to people who will support them, and people's sense of purpose and meaning. Portfolio 3 and 4 on this right-hand side is about improving the health and well-being of places. So the portfolio 3 is about working across partners in a community to address a specific thing that's going on. Is there an opioid epidemic here that you're experiencing at all? So it turns out that in places where healthcare systems have taken on the opioid epidemic alone, they've often worsened overdose deaths. Because as we deprescribe, people go on to buy street drugs like heroin and actually see an increase in overdoses. It doesn't mean we shouldn't deprescribe. It turns out what we should do is partner with communities to be able to do that, where there's Narcan administration across a community and policies around that, that make it possible, and a mobilization of thousands of community residents, a destigmatization of illness, and the ability to put chronic disease and supports in place. When you do that, then in that kind of whole system way, counties have improved opioid overdose deaths by 75%. We need one another. We need to go beyond our walls and collaborate with others to solve challenging problems. Did you know that there are 20 communities now that have almost ended chronic homelessness in their community? Do you know that? That's amazing, right? They've done that through coordination. You know, in those 20 communities where there are under 10 people that need to be housed, the one partner that's often been missing at the table? Healthcare across sectors. Because we tend to just do our own thing, you know? It's just what we do. But if we realize that we can be more than that, it'd be great to be able to pull up a chair at that table. We don't have to solve housing, but if we pulled up a chair and said, what could we do to help, so that someone who has mental health issues, who needs support in housing, can get preferentially into care for mental health. Sometimes all we need to do is to build the simple pathways that need to be there. We don't need to do all the work. Portfolio 4 is the one that I think called Communities of Solutions is really interesting. It's about actually growing leadership in communities that have been historically redlined and have experienced structural racism. But it's also about using our power differently and our assets differently. So as a healthcare organization, of course we deliver care, right? But what else do we do? Can you think about some things that you do that each and every day for your core operations? We mentioned one role, right? We're employers. In fact, we employ 10% of people in the country. What else do we do? We provide health insurance, great. What else? Think beyond care delivery. What do you have to do just Do you have to buy a lot of food to run your hospitals? So you're a food purchaser. Do you ever think about your food purchasing policy and how that changes the market economy of food availability? I bet most of you don't. What else do you do? You use a lot of energy, right? So you're an environmental steward in many ways, right? What happens to our products? Did you know that healthcare among industries, we actually often one of the worst contributors to environmental pollution and toxins, and many healthcare organizations don't think about what happens to the disposal of waste and where that waste is disposed of. What else do we do? We do a lot of education, yes, sure. What else? Do we do that education strategically? And do we do it after someone's already ill or before someone has become ill? What else do we do? Do anybody have an investment portfolio in their health system? Right? Do you think about where that investment goes, or do we usually think about where that goes? Do we buy a lot of goods? Like a few trillion dollars worth of goods, right? So Communities of Solutions is about applying an anchor institution strategy. It's about actually what places have done is look at those places that have those dark spots that have been the recipients of redlining, which have the poorest health outcomes, and actually historically look at what they could do to invest in those places. In Cleveland, 21 businesses, including healthcare and the medical school and the university, have come together and have looked at those places and adopted a simple policy called buy local, live local, hire local. Buy local means that in the final three vendors of any RFP have to be a woman or minority-led business from one of the zip codes that have the poorest outcomes around them. Hire local means that they build cradle-to-career pipelines into their institutions from those areas. And it doesn't mean 100% of hires have to be from those areas, but a substantial portion of them have to be. And then the buy local, hire local, live local is that they incentivize their employees to live in mixed income housing that are in the areas. What has that led to? Well, it turns out that it's led to about $500 million of investment into those areas. And this isn't about coming up with new dollars that you don't have. It's about changing your business operations strategically to undermine the places that have significant poverty. Does that make sense? Not to actually reinforce and strengthen and reverse a legacy of redlining to one of greenlining. And that kind of effort has been paid off in substantial ways for them. Employees that are actually much more loyal to them. There's less turnover. People feel more connected. They've built relationships with the other folks around them. In Chicago, this is happening across 21 hospitals. Places that are innovative in the country are beginning to do this. These four portfolios aren't separate. What we say is it's like retirement. You want to have a balanced portfolio, right? Because you don't want all your eggs in one basket. But it turns out that as you do all of this together, you actually accomplish much more together if you can align this. Now, I'm guessing if you looked at this and you really thought about what you're doing for community health and what you're doing for population-based or for value-based care and what you're doing maybe at an environmental steward, you have different initiatives going on, but they're not necessarily strategically aligned to achieve an outcome. Would you say that's probably true? How many of you think you have something happening in Portfolio 1 to improve mental and physical health? Are you doing something to do that? How many of you have something happening to address social determinants? How many of you are doing something in the community? That might be through community benefit, it might be through others. How many of you have something where you're thinking about your anchor institution strategies? Some people are, most people, that's a newer one for people, right? How many of you, if you're doing things in multiple ones of these, have decided to align what you're doing so that you're strategically achieving something, or have included all the actors in that into your population health team? Right? Almost none of us. It's because we're still working in Kristen's silos. We don't see how much we have if we were to put our strategies together. So that's my invitation to you, to actually think differently about what it looks like. And I'll share some examples of systems that are doing that. Intermountain Healthcare, 22 hospitals, 1,400 physicians. They started off early. They said, we don't really fully understand the social determinant thing, but What we can do is integrate primary care, mental health, provide really high reliable care, focus on mental health well, optimize the EMR so well so that poor people, they were able to save $500 million. And what they did was they used their payer function to return the money to employers in exchange for those employers using that money to create living wage jobs for their employees. Does that make sense? So it was actually using a lever in a very different way. Now they kept some of the money, of course, but they shared the savings. And that's a bold thing to be able to do, but that very directly affected social determinants. What's kind of exciting in Portfolio 1, remember that mental and physical health, most of us feel like we've got what we need. Well, it turns out that we actually often don't have what we need because we're only seeing people that hour a year. There's a network of beauty salons and barbershop owners who have begun actually teaching health messages while they cut hair. Now, there have been tons of studies of these kinds of efforts that show these are highly effective. A big part of our problem is we're not using the assets of community. How often do people get haircuts? Once every 2 to 6 weeks, right? And that, while you're cutting hair, turns out to be a really good time to talk with people. People have relationships with their barbers and beauty shop owners that are trusted relationships. And in communities where there isn't necessarily the same kind of trust, we can achieve much more together by doing that. The YMCAs have a pre-diabetes and diabetes program that they've launched and managed nationwide in hundreds of YMCAs that have achieved a 50% reduction of people going on from pre-diabetes to diabetes. That red line would have looked very differently in our graph at Cambridge Health Alliance if we'd had a partnership with the Y that was engaging people to do that. This was so successful that CMS made this one of the 4 innovative and effective, it made it the first preventative service that it cared for. We need to think really differently about mental health. Innovations like Big White Wall, which recognize that people have anxiety attacks in the middle of the night when all their psychiatrists are asleep in bed, is really important, where they have a 24/7 system, online system where a wall is being monitored, where in the wall, anyone can go and support one another with mental health issues. People can post on the wall, they share poetry on the wall, they share stories, they can join peer groups. Someone's always monitoring to make sure everyone's okay. You can even make appointments with someone and talk to them live if you need help working through something. These kinds of innovations have led to a $500 per person per year reduction in healthcare costs for 25% of the UK population, with over 95% of people not only feeling better, but most of them saying they would never have gone to their primary care doctor, letting them know that they were feeling ill. To address social determinants, I know all of you think like that means that you have to go and create your own community database. I'm here to tell you you don't. Groups like Aunt Bertha, 211, and others have already done it for you. Don't waste your time. Connect into these systems. Aunt Bertha, you can put in your zip code and find everything from employment resources and others. So my message to you is don't start over. Don't feel you have to maintain. Use systems that are already there. Massachusetts, I think, has its own system for connecting people with social determinants that you can access. But we need to actually address social determinants more strategically. Do you know how many care coordinators the average Medicaid family has? What would you guess? 5? Turns out between 5 to 15. It's because when we see someone struggling, we throw a care coordinator at the problem. And that we do that across sectors and we're not connected across sectors. So when we think very differently about it, strategies like the Pathways Hub, where payers contract with a neutral hub, which contracts with service providers, where we get much more coordinated across who produces health, lead to over a 50% improvement in things like birth outcomes, an almost elimination of black-white disparities in birth outcomes, and about $3.36 saved for the first year of life, both by getting operationally more efficient. Instead of everyone just throwing a care coordinator at the problem, everyone, whether you're the librarian seeing a pregnant woman who needs help, or a primary care doctor, or someone in the ED, refers into the hub figures out who they're connected with and figures out what they might do to help support them. And walks them through and makes sure with high reliability that they meet their goals. There are payment mechanisms where there's incentives put in for everyone who delivers that part of a pathway, So say a homeless pregnant woman might need housing, they might need primary care, prenatal services. And each one of these becomes a pathway that's closed, and as they close pathways, incentive dollars goes to whoever delivered the services needed. When the outcome is achieved, an improved birth outcome or healthy baby born at term, everyone in the pathway who's delivered services gets a significant incentive payment. This kind of modeling has led to substantially different outcomes. And the accountable health communities model that you're getting from CMS, tier 3 of that model is built on the Pathways Hub because it's been shown across states to be an evidence-based practice. Portfolio True, addressing social determinants, don't forget belonging. Palo Alto Medical Foundation recognized that seniors had a 6-fold higher risk of disability and hospitalization and death if they were socially isolated. They built systems where instead of having volunteers visit the seniors, they got the seniors to become the granimators or the silver tsunami, the silver army that could actually help people who are working to get things done. Like all those things that you didn't have framed on your walls that are the pictures that are on the side. I used to curate a museum, one senior said. I can help with that. By helping the seniors to actually feel connected and have purpose and meaning in their life again, they could actually improve health outcomes. They used their community benefit dollars to do that and found a ton of ACO savings, began reinvesting the savings as a result. So it's thinking differently about how we use all our buckets and assets to get better. Right here at Cambridge Health Alliance, by going outside our walls, connecting with the schools and the housing department, we were able to improve asthma outcomes, all cause for all kids with asthma by hospitalizations and ED visits for between 50 and 90%. And that's by recognizing that actually the school nurse had much more access than we did. And that when someone, a nurse went out to actually do an asthma home visit at home, they could see where there was mold and let the housing department know. We actually had the solutions to each other's problems. So my friends, my message to you is that we don't have to work harder. We just need to work in closer partnership. We need to realize there's a wealth of assets and abundance out there if we can think differently. And if we can think differently and see the whole person, it is the most efficient way to actually get to improved health outcomes at a lower cost. And when we do this, sometimes we can do this in a way that achieves abundance for everyone. I was telling you about those buy local, live local, hire local policies. Dignity Health in San Francisco, and they're actually all across the country, they take their investment portfolio, their retirement portfolio, and invest a portion of them into low interest loans for women, for actually minority-led businesses and nonprofits that are trying to do good in the communities that aren't doing well. You know what the return on that investment portfolio has been? 20 to 1 compared to the rest of their retirement portfolios. It is possible to do good and have it be good business practice. And that's really what we're asking you all to do, to think differently about how to do good business as a way of doing good. Thank you all so much for having me here. So what you can do, I invite you to think differently. Please join 100 Million Lives. We need you to get to 100 million people lives improved by 2020. Think about your assets differently and chart a path to action with partners that you might not currently use. Thank you so much. Time for questions. I think we have time for a few questions.
Hi, I'm with the, Jeff Turgeon, I'm with the local workforce board, and we've established a consortium of healthcare providers and folks that do the education and training. And I'm just wondering if you know of any good examples at cradle to grave, the career pathway models that are out there, any good examples we might look at to help solve some of the challenges folks are facing.
Sure. And so there are really terrific cradle to career pathway solutions. So Ready by 21 is an excellent organization that really says what this looks like across the board. Bottom Line is a great Massachusetts and New York-based organization that really breaks down what needs to happen at each stage. And then Purpose-Built Communities has a whole playbook for cradle to career pathways as an investment. So part of what we did in 100 Million is figure out who's got solutions, right? If we think more broadly than healthcare, how can we connect the people who have a part of the solution to those who might be looking for it?
What was that
purpose-built communities. There, it's about economic development, housing, affordable housing, economic opportunity development, and cradle-to-career pathways together.
Just a quick question. What can we do to improve the food system and allowing there to be a little more equity relative to nutritious foods being in all different neighborhoods, you know, instead of that disparity that we see today?
I'm so glad you asked that, because it's one of the things that healthcare, like, not only should we care a lot about that because we're only going to treat it after the fact, it's actually one of the things we can do the most about. So if we change our supplier, so we influence suppliers a lot because we buy a lot of food. So they care much more about what we think than what a local community organization or neighborhood thinks about what kind of food should be available. So if we use our power to say, actually, both while they're within our walls, but also for the food that you're giving to these communities, you need to adhere to certain practices, they're much more likely to listen to us. And we can actually make that part of our contracting as a stipulation for what they do as a way of enacting that. And that doesn't really cost us something. It does have some huge impact in terms of availability. In addition, if we're buying healthier food for our own hospitals and clinics, then that actually reduces the cost of healthy food in that place. When you combine that kind of sort of contractual action together with things like community benefit action, it turns out that with the USDA Farm Bill, any investments made in food and community benefit dollars can now go to support healthy food, and anything that we put in is matched by the Farm Bill. So it's actually like a double, like a 2-for-1 kind of investment that we can do. And people have used that to get healthy food in local convenience stores, all the way to supporting food programs that really help mobilize communities. A third thing that we can do is really invest in engaging sort of food policy in our local area. So what kind of food is a food bank giving out? Often pretty unhealthy food if you really look at it. Or how do people in the community get engaged to know how to cook and engage in food production as a way of development? So in communities around the country that are involved in 100 million now, it turns out that if you just get healthy food into a community that has never used that food, that isn't a successful strategy either. So actually engaging people to help grow the food, for instance, in community gardens, is a really effective community engagement strategy. And if you can even just change, for instance, who you cater from to be from food cooperatives that are, instead of providing healthy food out there, pairing food creation in the local community with jobs and business contracts with us to be able to use that, is a really effective strategy in addition to what we might do for education. Does that make sense? Like, that can be a pathway for training and job development, et cetera. Healthcare Without Harm has just created a great playbook for how to take action, which has policies, tools, resources. And some of what we've been doing in 100 Million Lives is just putting all these together in one place so that if people want to take action, it can get much easier and we can be much more creative. Any other questions?
Just to add to the foods, have there been strategies around working with schools to help them, like with the lunches? I come from attending the public school system, and I remember that the lunches were not healthy. So you had mentioned that you impact, the health by 44 folds if you impact the children. So is there any strategies around that?
Absolutely. So I'll tell you a local example and national example. So the health and school partnerships are one of the most strategic ones we can make. So at Cambridge Health Alliance, we actually worked with our schools to invest some of our community support dollars to help them build programs that would engage in providing, first of all, getting access to breakfast and lunch and having those be healthy, where students ran PDSA cycles with their peers about how to make that accessible. So that's, and then actually get their peers to engage and use it with youth-led food systems. So so actually what we could do is invest in those and support people who can really support kids and youth to take over their own food system in a way. What we've learned is that that's incredibly effective across schools. Schools all across the country are actually now part of 100 million, and youth are leading those initiatives and often getting as much as a 6 to 10-fold increase in students buying, even when they're buying lunch, buying the healthy food. So it's one of the critical places that we can invest. And again, we can say, hey, Sodexo, which is who's providing food to most of these schools, if you're going to provide healthcare food to our healthcare system, we also need you to provide food, healthy food to schools. Because often in these places, students have had to make bets with them where they've said, nah, we're not going to put a salad bar in because we don't think anyone will buy it, which is not really what we would want as an outcome. So our ability to say, hey, Sodexo, we actually need you to do that for the schools too, not just for us, can make a big difference. Yeah. One more question.
Hi, thanks. You know, at UMass, we're just embarking on the anchor mission. As a matter of fact, that's where I'm going after this meeting, is to a steering committee for that effort. And I'm wondering if we've connected with you on this yet.
I don't think so.
I'm thinking
We would
not,
love to
because
have
you
you.
might have mentioned it. So definitely to come, because we're perfect timing.
That's terrific
Yeah,
to
it's
hear.
really exciting. Actually, yeah. Can you make it 11 o'clock?
I wish. I'm heading out to the IHI National Forum right after this, where the entire forum will have a theme that's around, we're really at IHI, the American Hospital Association, we're putting all of our weight behind what we think of as really effective strategies for healthcare to be able to address and use its power to address social determinants in ways that make sense for healthcare. And it really, if we use our power as a sixth of the economy, we can change the tides of health outcomes. And it's not just what we do before us. That's an incredible power we have as with people, but our policy power and our economic power is immense if we choose to use it strategically. And I thank you all so much for having me here, and I thank you to the Worcester Business Journal for having me for this important conversation.
Hold on, I'm going to give you one thing. Thank you, Dr. Stout. That was terrific. By the way, we had an event back in early November where usually it's, you know, we're used to 50 degrees, and it actually snowed that day. So Chris, I know, got a little nervous and said, Soma, you're our keynote speaker in the morning, and so we convinced her to stay at the Beechwood. So she had a lovely time in Central Mass, and so we're giving her a nice photo book of all the beauty of our region, heart of the Commonwealth. Even though she spends most of her time in Boston, we hope she comes out to Worcester and Central Mass a little more often. Thank you so much. Wow. You know, it's interesting in your talk, and we didn't reference sort of where you get all the data, but I thought every single point you made, there was statistics, and there was an ROI, and there was support of that from the data side, which I think we all recognize as an important part of, you know, not only doing good, but being able to measure it and show those results. So thank you so much again. I'm going to introduce our moderator, who's going to have a few comments first, and then she's going to later on bring up our panel. We're going to have a panel conversation. So our moderator for the next part of this morning is Dr. Carolyn Langer, who's the Senior VP and Chief Medical Officer at Fallon Health. Dr. Langer is responsible for ensuring the quality, and this is an annotated introduction because her full bio is in your program. She's responsible for ensuring the quality and cost effectiveness of healthcare services for Fallon members, including its program of all-inclusive healthcare for the elderly. She previously served as Chief Medical Officer at Mass Health and the Director of the Office of Clinical Affairs. She was previously, she's a retired colonel and former flight surgeon, also in the Army National Guard. So please welcome Dr. Carolyn Langer.
Thank you, Dr. Stout. That was a fantastic presentation, a lot of rich material, and really an excellent lead-in to our panel discussion. So we're starting to hear a lot of common themes here, starting from the first remarks this morning, themes around fundamentals, getting back to fundamentals, and addressing some of the social determinants of health. In addition, Dr. Stout really so nicely highlighted addressing the whole person viewing medical care as one of many factors in driving health outcomes. And I particularly love your model looking at the interrelationship between health, well-being, and equity. I think perhaps one of the most significant comments that you made was that health creation really does require a partnership, and we are so fortunate here in central Massachusetts to have many partners who are passionate about working together to advance and improve care and its delivery. So, you know, when we get into forums like this, I think sometimes it's easy to kind of focus on the theory and the policy. So I always like to start out these forums with a case study, just to remember to keep the face of the patient, or member as we call it on the payer side, front and center. Now I wish I had a great photo. I love that photo you had of the 2 kindergartners. So I didn't have a nice photo like that, so just visualize our member up here. But I want to tell you about one of our ACO cases. So Dave Prezik mentioned that we just launched the Mass Health ACO initiative in March. And while we won't have the full set of outcomes yet for several more months, anecdotally I can tell you that we are seeing that these partnerships are truly making a difference. So I'm going to tell you about this 62-year-old Latino male for whom English is a second language. He had frequent visits to the emergency room and frequent admissions to the hospital, arising out of his history of substance use disorder, COPD, or emphysema in layperson's terms, and most recently pneumonia. So our Fallon team met with our ACO partners and with their integrated care team, which comprised the primary care nurse practitioner, a social worker, an RN, and a community health worker. And when you think about the care plan that Dr. Stout put up, that Kristen Lind developed, whom I, by the way, had the pleasure of knowing and working on a task force with, it really is so complex, and you can begin to appreciate all the different ways that we have to address the many factors that are really driving health outcomes in these patients' lives. So in this particular case, the Fallon team partnered with the ACO team. We met with the primary care provider. We ensured that the patient got a full pulmonary workup for his pulmonary conditions. One of our pharmacists at Fallon reviewed his medications, was able to help tweak his medication regimen and ensure greater compliance. In addition, we did actually in this case have to seek an involuntary commitment, what's called a Section 35 to inpatient detox. But I'm happy to report that following that detox, we were able to connect this individual with one of our behavioral health community partners, which is a new part of the ACO program, to ensure that he got adequate behavioral health follow-up. In addition, we set him up with weekly visits by one of the community health workers at the ACO, who, by the way, was culturally and linguistically competent. In other words, understood this individual's culture, spoke his language, and also were able to get this individual into weekly Narcotics Anonymous support groups. I'm happy to report that he, to this day, remains sober and has had a significant reduction in his utilization of both inpatient and ED services, and has really restored significant quality of life. So this is a real success story. I realize this is only one of many anecdotes I can share with you, but I think it really drives home the point that this could not have happened without these different partnerships between us, our ACO partners, and our community partners. So as we think about how we are approaching the delivery of health care, I would just like to mention that at Fallon, we see firsthand how innovative models of care can positively impact health outcomes and lower costs. Our integrated care models, ones that bring together physical, behavioral, and social care needs, are doing just that. You heard my colleague Dave Prezik earlier mention Fallon's participation in the Mass Health ACO program and the Summit Elder Care program. It's been rewarding to be a part of the changes in the approach to treating and serving these members, the coordination of healthcare professionals, community partners, and Fallon as the payer is addressing whole person care and really making a difference. We've learned how effective this approach can be from our experience with many of our unique programs, such as our Summit Elder Care Program, which is our program of all-inclusive care for the elderly, our NaviCare program, which is our senior care options program, and our Medicare Special Needs Plan. These programs offer adults and their caregivers innovative health care and support. They provide care teams as well as benefits that address both the medical and social needs. For example, at our Summit Elder Care, many of us had the privilege of celebrating the 10th anniversary yesterday of our Grafton Street site. It was really wonderful to see. But each morning, the integrated care team huddles and meets to talk about a participant's progress. The care team is made up of a primary care provider, a nurse, a social worker, a nutritionist, a home health specialist, a physical therapist, transportation staff, activities coordinators, and so many others. They share information and viewpoints to help develop creative and practical solutions with the goal of helping participants be as independent as possible, as long as possible. The participants come to our Summit Elder Care sites where they receive their care, but they can also take part in daily social activities. Again, that social connectedness and that addressing that social isolation that Dr. Stout referenced, and engage in other activities such as exercise groups, baking groups, even karaoke. Healthy meals and transportation to and from the sites are provided, and we've also begun embarking on some supportive housing partnerships with some of the municipalities, including the city of Worcester. And we are seeing really remarkable results, not just in lowering utilization, but more importantly, in keeping these seniors safe and happy and improving the quality of their lives by being able to keep them at home in their communities. So we often say this is the way that healthcare should be, and I am very encouraged to see that healthcare continues to move in this direction with more integration between physical, behavioral health care, long-term services and supports. And I know that there's at least one of our LTSS community partners, HMEA, in the audience. I'm not sure if any of our other community partners are here. But really looking at many of the social needs as well, and how we pay for these services. So I'm really inspired by the innovation we've already heard about this morning and look forward to sharing more ideas that will come from our panel. So the way it's going to work is I'm going to bring up one panelist at a time who will make some remarks for about 5 minutes. And then after each panelist has had a chance to comment, we will take our seats here and have a Q&A session. So I will start by asking some questions, and then we will open it up to the audience. So at this point, I would like to call our first panelist up, David Seltz. So David Seltz is really just a remarkable person. I'm not going to go through all of these bios. I think it would take half the session just to go through everybody's bios. But what really impresses me about David is, apart from the fact that he is a genius, he is the first and only executive director of the Health Policy Commission, and you were appointed to the HPC in 2012. So, so you heard I was at Mass Health. I was there for a little over 5 years, and I thought I was a dinosaur. So really remarkable that David has been in this role, the first and only, and we hope that you will continue in that role because you are really driving change and bringing a really important perspective to the state. So with that, I'd like to call David Seltz up. Thank you.
Thank you. Well, good morning, everyone. It is really great to be here today. Great to be here in Worcester, and great to be here at this forum. Thank you to the Worcester Business Journal for hosting this. I'm David Seltz. I'm the Executive Director of the Massachusetts Health Policy Commission. So for my 5 minutes introduction here, I wanted to kind of both take a step back and kind of take a step up and talk a little bit about where we are as a Commonwealth on some of these big healthcare policy challenges. And so To do that, I always like to start the story 12 years ago, which is in 2006 when Massachusetts passed landmark healthcare reform legislation that at its core made a promise to the residents of this state that they would have access to affordable, high-quality health insurance, and that healthcare access was a right that we would provide to every citizen. Obviously, this law, which is sometimes called Romney Care, sometimes called Chapter 58, was a huge success here in the Commonwealth and became a foundation in many ways for the Affordable Care Act and for the country. But really, that entire law was focused on expanding access. And I worked in the state legislature at the time and had the opportunity to work on that bill. And after we passed that bill, and I think very strategically, we didn't really try to tackle the cost problem. But after that bill passed, we knew that that was the next thing that we had to do. If we were going to make this promise of having great healthcare access, we had to make sure it was affordable and sustainable in the long term. And so as policymakers on Beacon Hill really shifted their focus to saying, how can we make healthcare sustainable and affordable? We looked at the costs in healthcare in Massachusetts, and in 2009, Massachusetts had the highest per capita healthcare costs of any state in the United States. And for those of you who know anything about healthcare costs and per capita healthcare costs, the United States has the highest per capita healthcare costs of any developed country in the world. So basically in 2009, Massachusetts was the most expensive place on planet Earth to get healthcare. And it was growing at double-digit rates. And what this meant was less resources for everything else. So from a state government perspective, we were seeing double-digit increases in how much we were spending on healthcare in our state budget, which meant less money for transportation, less money for education, less money for cities and towns, less money for mental health. And that same story was playing out for our businesses and our employers, who, again, had revenue growing, but at a much lower rate than their health insurance costs were going up. So our employers having to make really difficult decisions about, do I continue to provide really good benefits to my employees, or do I give them a wage increase, or do I hire more employees? And having to make all of these trade-offs, and ultimately, in many cases, making the decision to move to high deductible health plans and shifting more of those costs onto families, which is the third part here. Because families were seeing whatever wage increases that they were getting completely swamped by increases in copays and deductibles and their monthly premiums. So we saw this crowding out effect that where healthcare and healthcare costs were just absorbing all of these different things. And so in 2012, Massachusetts passed another landmark healthcare bill, which set as its goal to try to reduce the growth in healthcare costs. And during that debate, I think it's really important to know that there was some talk about having government really kind of take over healthcare and set prices and really regulate the healthcare system and return to kind of a government price-setting system for healthcare. And ultimately, that's not what passed. And ultimately, what passed was still relying on the private market, still relying on our health insurance companies and our hospitals and our providers working together, but also set as its organizing principle this idea of a goal, an idea that we would all work towards together to bring healthcare costs down to a growth rate that was more tied to the growth rate of everything else. And so this is the healthcare cost growth benchmark. This is set in law. And to steward and to help ensure that the market was able to meet this goal, which is growth of 3.6% year over year, it established a brand new independent state agency called the Health Policy Commission. So I have the honor and privilege of being the first executive director of the Health Policy Commission. I literally started this job 6 years ago, almost to this day. I was the first employee. I didn't have an office. We didn't have furniture. We didn't have copiers or telephones or computers. We were truly a startup state agency. The place where we first had our office was extra space that another state agency wasn't using anymore, and they were using it for storage for garbage furniture. And I would come in on the weekends and dig through all this garbage furniture to try to find the one chair that still worked, the one desk that had drawers that would work, and begin to set up an office for this Health Policy Commission. I report to a board of 11 experts in the healthcare industry, and they have different roles. We have a healthcare economist, a primary care provider, a behavioral healthcare expert. Secretary Mary Lou Sutters, our Health and Human Services Secretary, sits on my board. So I do report to a really excellent nation-leading board of experts who help guide the work of the commission. And really our job is to be a watchdog, to be a partner, to be a researcher, to be a convener, to try to help work with the healthcare industry to meet this goal of lower cost growth. And I'll talk more about what things we've done during the panel, but to fast forward, now we've been in place for 6 years. How have we been doing? In 6 years, our average year-over-year growth has been 3.2%, below the 3.6% target that we set for ourselves, and a dramatic difference from where we were before this bill was passed. And in the latest rankings of where Massachusetts sits, we are no longer the most expensive state in the country. We're number 2. But Alaska has overtaken us as the #1 most expensive state. And in the most recent year that we measured our healthcare cost growth, from 2016 to 2017, we had 1.6% growth in healthcare costs. That is a success story for this Commonwealth and for everyone working together. But there's a lot of work left to be done, and we'll talk more about that on the panel. So thank you, and I'll let my fellow panelists join me.
Great. Thank you, David. So I'd like to call up to the podium John Greenwood. John is the president of the UMass Memorial Accountable Care Organization and the senior vice president of population health at UMass Memorial Healthcare. So he'll make a few comments, and then we'll be joined by our third panelist.
So good morning, everyone. Thank you for the opportunity of the Worcester Business Journal to serve on this panel, and I want to thank my colleagues for being here this morning, as we really, I think, is going to have a great discussion around this. Specifically, it was really well received, Dr. Stout's presentation. I think what struck me the most, and again, I'm a numbers person, but what struck me the most was that diagram that patient drew, putting the family at the center and all the care around that. Because at UMass Memorial Healthcare, specifically in our accountable care organization, our population health, and as a system, that's kind of how we view the patient. That's how we kind of work together to kind of help that patient through the system. So again, my name is John Greenwood. I'm president of the UMass Memorial Accountable Care Organization. So what is that? That's a Medicare ACO, and what we are as part of the Medicare Shared Savings Program as a Track 1 ACO. So again, Track 1, what does that mean? That means that we're in the program for shared savings, so upside only, no downside risk. So as we share, as we have savings, we share with CMS back to $1 as long as we hit a minimum threshold, 50-50. And so it's shared savings, upside, no downside risk. We've been in the program since 2015, so our first 3 years was 15, 16, and 17, and we just rejoined or renewed in that program as a Track 1 ACO for 18, 19, and 20. When you take a look at our ACO and the construction of our ACO, you can see that it's a pretty large ACO. We have basically organizations across the region, so multiple hospitals, not only local to UMass Memorial Healthcare, our hospitals here, but we also have Haywood, we have Harrington, we have Holyoke out west, and then we also had, back in 2017, Sturdy to the east. That whole network of hospitals was then backdropped with 4 federally qualified health centers and over 1,900, a little over 1,900 providers providing coordination of care around those patients. So basically trying to help manage the cost and quality of that population. So when you take a step back and you take a look, the next question obviously is like, so how well have you done in the ACO? What's your results? What are you showing? So in 15 and 16, we didn't have shared savings. We obviously had a trend in the right direction. But in 17, we had shared savings. We actually shared in $22.6 million of savings with CMS, which you heard in the beginning put us at #1 in New England around Medicare Shared Savings Program ACOs. And we received a check from CMS of a little over $9 million back to our ACO to continue the work that we're doing across the network. So we're very excited about that. I mean, talk about sharing that. I guess I share that with the World Series with the Red Sox. We're very, very excited. I kind of take a step back and think of days in my career, there was nothing better than getting that news, calling the whole team together, and celebrating that success, because we had the team, the network, the board of the ACO, the UMass Memorial Healthcare System, who had backdropped this, put a tremendous amount of effort into this program. It was great to be able to show that we were actually moving the needle and actually having savings. So very, very excited with that. And of course, when I get up in front of everybody, I always want to acknowledge my colleagues as part of the population. So if you could just raise your hand, because without them, the provider, the networks of providers that we have, the hospitals, the institutions, and the collaborative partnerships that we have, I couldn't be up here telling that story. So I thank you for all the work that you have done and continue to do with that. And again, I look forward to coming here with more results. So the obvious question after that is, well, how did you do it? Kind of what Dr. Dixon asked me is like, what's the secret sauce? Like, what worked as you kind of take a look back? And so taking a step back, thinking about and really looking at the data, because everything that we do is driven by data, we really kind of boil it down into a few points. One is around transitions of care, really helping that patient through our system. As anyone knows, trying to navigate a healthcare system, even when you're part of that healthcare system, can be very, very challenging. And so us working with the beneficiaries to help them get through the system, so right care, right time, right place, was a very important piece to us having savings. The second piece was really around our work around readmissions. So as patients get discharged out of the hospital, we don't want to have them come back as a readmission. That's an additional cost. It's not good patient care. So we've worked really close with our local institutions right here in Worcester to really kind of help that readmission work, keep the patients from coming back into the hospital after they've been discharged. And that was a really big contributor as well. And of course, the chronic disease management was another really big piece. So you know, around kidney disease, pulmonary, heart failure. Those are the programs that are prevalent within our beneficiaries, and that was what our focus has been and will continue to be kind of going forward. And so with that, you know, we kind of look forward of what we're continuing to do. Not only are we going to continue those programs and really kind of progress those along, but we're also looking at new innovations. And again, Dr. Stout's presentation today really honed in on socio-determinants. And it's interesting, of all the things that I've learned in this position, again, being a finance person by trade, a few years back and talking to our care managers is really around that socioeconomic piece. That was kind of I always say is my big aha point. It seems so obvious, but until you look at the data and try to really understand the beneficiaries and what they're dealing with, and then kind of take your personal experiences together, you don't realize how big of an impact it is, and it does. It's got a tremendous impact. So what we're continuing to do and try to focus in on is how do we understand those determinants, and how does that help our patients and keeping them well, keeping them at home, and keeping them out of the hospital. And that's our big focus. And one of our innovative ideas is really taking all our beneficiaries, knowing where they're located, and then overlaying a map of their communities, not just by zip code, but getting down to the neighborhood level to understand where those socioeconomic problems might be, so that for a couple reasons we can figure out if there are any gaps in that coverage that we can help with, i.e. housing gaps, food gaps. And then two, knowing our beneficiaries for our care managers when they walk in to help them go through the system, know that ahead of time so they might have those resources with them available so that they can figure out transportation needs, they can figure out food, et cetera, to really kind of help the care of that patient. And we're just starting to roll that out, so we're very excited about that, because I think that's going to be a game changer for the whole system, not only for us, but also our partners as well. The second piece I think is going to be really innovative, because you just don't see a lot about this, is the discussion around the cost of prescription drugs. Right, I know it's come up, it's going to continue to come up quite a bit. But when we take a look at our patient experience scores, one of the areas that we really struggled on is that communication, what they call stewardship of resources. And it's really one question that's asked as part of this patient engagement is, did anyone on your healthcare team talk to you about the cost of prescription drugs? And so we didn't score so well. So in talking to our network of providers, we put it out there. It's like, so what do you think? What happened here? And they're, whoa, can't talk about that because I don't have any information to provide. So we saw a huge gap coming out of the gates with that. And it was no wonder that we can't score that well if we don't have documentation to help that engagement or that communication back and forth between the patient and provider. So we're, again, just rolling out now a whole mechanism of communication so that that provider can have that conversation, hand the patient a pamphlet with all those resources, and basically engage in that conversation around that. And again, I have not been in a place myself that I've seen that, so we're very excited to see, as we deploy that out there, what the impact's going to be. Not just so much for the school, but how is that going to help the engagement between the provider and the patient moving forward. So to me, just to kind of sum it up, it really comes down for us in innovation going forward around two items. It's really around communication and engagement with the patient, provider, and the system. And then it's around the innovation of how we continue to focus in on that data to help make our judgment and move forward on interventions that we think are going to benefit the beneficiary as well as the system as a whole. So we're very excited about that. And again, I'll get into some more detail on the panel. Thank you.
Good, thank you. So you're already starting to get a sense of all the innovation going on here in Massachusetts, particularly in central Massachusetts, and some of the many partnerships both within organizations and across organizations. So last but not least, I'd like to invite up Dr. Mike Sheehy to the podium. He is the Chief of Population Health and Analytics at Reliant Medical Group, which is one of Fallon's 3 ACOs, so we've had the pleasure of working very closely, and I think you'll enjoy his comments as well. Mike, thank you. It doesn't matter.
Good morning. Healthcare costs have been a passion of mine for my whole career, and quite honestly, it really feels like it's been a burning platform for about 25 years since the mid-90s. Really briefly interrupted, I think, by the recession, but there are some areas on the horizon where I think it's threatening to bring healthcare inflation kind of roaring back, and I think we'll get into some of those probably through the discussion. But I want to touch on 3 areas of innovation in our organization and just a little bit about who we are. We are a medical group practice of about 300 physicians, 200 advanced practitioners in central Massachusetts and Metro West. We manage about 300,000 patients. We were started back in 1929 by Dr. Michael Fallon, who was a surgeon, trained at the Mayo Clinic, and he wanted to bring back this new concept of collaborative care that the Mayo brothers were teaching. That really, it brought together physicians to discuss cases individually for better patient outcomes. If we fast forward now 90 years, we're going to celebrate our 90th birthday next year. All the buildings that we're putting up, we're investing $186 million in Worcester County, are largely in new primary care facilities that are built around a new advanced care team model that really has been led by Dr. Thad Schilling, who's been a real innovator in this area. And in these new team care spaces, physicians don't have their own offices. It took a little doing and talking and many discussions to get physicians to buy into this, but for those that have moved into some of the new facilities, both the physicians and the staff really wouldn't have it any other way. It really fosters real-time communication. Patients call into their own team care. The calls are met by their own team care nurse. The physicians are right there in the same space along with their advanced practitioner and other team care members. It fosters improved communication. Some of the early indicators that we've seen, we're getting better quality outcomes, better cost of care, and better patient satisfaction. If any of you have a chance to look at or have seen some of our new spaces, it's really worth going through. We just had a ribbon cutting last night up in Leominster with another new facility. We're on a 3-year aggressive timeline to get these built, and we're opening up new facilities about every other month. We're going to finish May of next year. So real aggressive and very, very innovative team care space. The second area I want to mention is about our analytics. We have global risk contracts for many of our patients, and with that we've really had to build in infrastructure to manage a total cost of care. We have a group of analysts and software that provides our primary care providers really all the tools that they need to see how their patient population is performing. They can open up on their desktop software system that will tell them the total cost of care of their patient population, their utilization in the emergency room, their utilization in hospital admissions, 30 some odd quality measures, and all the gaps in care that those patients might have. And those are all bumped up against our corporate expectations so that we can look at managing outliers both in patients and in performance. We also couple these up with predictive software models that tell us who the patients are that are most likely to get admitted to the hospital in the next 6 months. And those lists populate rosters that our care managers, who are embedded in the primary care sites as part of the team, work off of to do outreach to patients, as a lot of us heard about patient engagement is so important. So our analytics and software also allow us to do some disease hotspotting. So we can tell geographically where we have higher numbers of patients that have specific types of disease burdens, higher incidence of behavioral health issues or substance use disorder, so that we can appropriately allocate resources within our organization. It's been very, very effective and very useful. The third area that I want to mention is our home run program. We noticed several years ago a big gap in care for some of our oldest, most frail elderly patients who were becoming homebound. These patients couldn't get in to see their physicians in the office, so we brought primary care services out to them. We started this several years ago, and it's run by our geriatric department. We have one geriatrician who oversees 5 geriatric advanced practitioners. And that model has been so successful that we've expanded it now 3 times. We cover all of central Massachusetts, from the New Hampshire border to the Connecticut border, from Spencer to Framingham. These patients, we've looked at their data for, actually I've done 3 data pulls over the last several years. I've looked at these patients, their pre-12-month spend and utilization, and their post-12-month spend for patients that are continuously enrolled in this home run program. And we've reduced the cost of care by 30 to 50%, and it's largely driven by a reduction in hospitalization. As you can imagine, these patients, if they're left at home with very little resources, they're often found on the floor by an adult child and brought into the emergency room, and that cycle just repeats itself. This has been so successful. It's one of those real sweet spots in medicine where you can show that better care actually is less expensive. So again, we're expanding this. We follow some 600 or 700 patients now. We're expanding it to 1,000 patients. Patients love it, the families love it, and of course we love it. So I could go on, but I'll stop there, and I know we have an awful lot more to talk about. Thank you.
Thank you. So I think everybody can appreciate we could probably stay here all day and just fill up this panel with questions. So I do have some burning questions, though, and then we'll open it up to the audience. But really fantastic expertise on this panel. Again, you've heard many common themes. I want to just probe a little bit more deeply. So David, let me start with you. We have heard a lot this morning about alternative payment models, the CMS Pioneer ACO, and now most recently the Mass Health ACO. You know, I feel like we still have one foot on the fee-for-service dock and then one foot in the value-based alternative payment model boat. So my question to you, and then we'll open it up to the other panelists, is are these models gaining traction? Is this the direction we should be going in? And if so, what do we need to do to get to that tipping point?
So one of the key strategies that we've had in Massachusetts is changing the payment structure and moving away from the hamster wheel of fee-for-service, where you get paid for doing stuff and you get paid for doing the most complex stuff in the most expensive settings, and trying to create the financial incentives for providers, such as my fellow panelists here, to do the right things for their patients, keep their patients healthy, keep their patients well, and not hurt their own bottom line to do that. And as you said, we're still in a bifurcated world, and I'm interested in my co-panelists' thoughts on this as well. But basically, if we look statewide, our uptake in terms of these different types of payment models is stagnant. We have kind of leveled off at about 30 to 40% of payment that's kind of in this new model. And that's a big problem because, as you said, and there's a lot of different metaphors, it's the canoes, it's 2 different feet, all these different things, but it's creating some sense of schizophrenia from providers. And so I'll just, you know, not to name names of this particular provider, but I'll share a story. We were working on a grant program with a provider and basically doing some of the same things that we're talking about here. Keeping people, the goal was to reduce hospital readmissions. And we did, basically what has been talked about all morning, a care team that went to those patients back in the community after the hospital discharge, a community health worker engaging, and the program was a success. And we saw dramatic reductions. But it was a grant-funded program when we were paying for kind of that care team. And so I went and talked to the hospital, the health system, at the end of the grants, and I said, are you going to keep this program going? It's working. And the CFO of this health system was in the room, and he was very candid, and he said, why am I going to continue to pay money to lose money? And that's pretty depressing, because it was a program that was working, it was keeping people well, but he said, I get paid when people show up in my hospital, and this program is keeping people out of my hospital. And at the same time, in the room was their population health person who's like, this is the greatest thing ever. We love this program. So we have this divide between the CFO and the population health management people in many of these organizations. And the decisions and ultimately the right decisions aren't necessarily being made all the time. So that's why the payment models matter, is because we have to get the CFO to be invested in this transformational change.
So let me just ask you one follow-up question before I throw this question out to the other panelists. How do we drive more providers into these alternative payment models? And is there something that employers or payers could be doing? We do have a number of employers in the room as well.
So, I think it requires a commitment both on the payer side and on the provider side. I think we do need to kind of push more towards downside risk, not just upside risk, but actually having providers take downside risk. And employers do have an important role here, because when we look at the data and we look at where these payment models are basically non-existent, it's for the self-insured insurance market. So these are employers who are making decisions that say, I don't really want to be on this pathway. I like it the way it is. I don't want to have to, in some cases, yes, invest a little bit more money. So employers, and especially self-insured employers, need to be talking to their health plans and saying, no, we need to be able to change the way that we're paying and be a part of this journey. So it does require effort, I think, from all of those different component pieces.
Great. I'm going to come to John now, since you did such a nice job highlighting the success of your Pioneer ACO. So what more does UMass need to do, or do providers in general need to do, in order to move the needle and really get traction for these alternative payment models?
Yeah, so our ACO is actually part of the Medicare Shared Savings Program, so it's not the Pioneer, it's not the Take Risk ACO, so I just want to make sure that's clear. But the other piece, I mean, you talk about the program, and I think the key point with CFOs is financial sustainability. So you talk about grant, and I think the biggest challenge out there is that we can't run programs that are not sustainable, and that's a challenge. So when you're sitting in a room with a CFO, you're getting the exact reaction to making sure that that institution stays financially viable for all the patients that they serve, even though you might be talking about one distinct program. And so from my perspective, what it kind of comes back to is really working with the providers and talking, what's the program for the patients that need to be out there to, again, effectuate change, to make them healthy, keep them at home, try to keep them out of the hospital, and then push that up, and then contract, from my perspective, around that program that's going to help the patient, therefore trying to align those incentives. Because once those incentives are not aligned, you're going to get the different answer depending on who you speak to within the organization. And then, it's very easy to say take downside risk, but again, having been a CFO for so many years, you're responsible for the stewardship of those assets across that whole institution for the whole care that you provide. And taking downside risk is really making sure you have the balance sheet to be able to do that, and that's not an easy process. And with that, you need upfront investment to make those changes around care. So, I think if we focus and work with the providers, come up with the programs around the patients that make the most sense for those patients and all our patients, and then push that up, I think we'll end up with a much more viable system. And it could be a mix. It could be fee-for-service for some things. It could be value-based care for others, because having lived back in the capitated world 20 years ago, I think the biggest missing point there was we're obviously electronically way beyond that. but there wasn't quality. Now when you infuse quality as well as the electronic means to move information around, I think our greatest opportunity exists today. And then just one other point that I think is going to drive that, which we've talked a little bit about, is the consumer. Right? So when we talk about value-based care, I can ask anyone out here and everyone's going to have a different answer of what value means to them. I could talk to my parents and I'll say, Dad, what does value mean to you? And he said, I don't want to drive 15 miles to my appointment. Well, I want to go right down the road. You can ask me, John, what does value mean to you? Well, you know what? I want access. So I think we have to make sure that our definitions are succinct as well.
That's a great point. So Dr. Sheehy, you've been a part of the Felon ACO for the last several months, but I would argue that really Reliant has been functioning as an ACO for probably the last 40 years at least. Right. So from your vantage point, what's working, what's not working?
Yeah, I think payment reform in Massachusetts really is kind of the last area of healthcare reform that needs to be addressed, and it's such a fundamental issue. You really need all of the major stakeholders to be aligned. As long as hospitals make a margin by keeping their beds full, and we make a margin if they're empty, we've got a fundamental problem. And I think there are ways to address it and deal with it. I think the DRG payment model for hospitals was one step in the right direction, but it's still it's just an iteration of fee-for-service medicine. I think populations can be attributed to a home hospital, if you will, and I think that we can work together to pay for outcomes in hospitals. Imagine if hospitals got paid to keep their beds empty. I think we'd see a fundamental change. Business models drive behavior. So I just think it's going to take a lot more work to get there, but we have to get the major stakeholders at the table, and that, I think, includes the hospitals.
Great, and I'm sure we'll have some more questions about this when we open it up for Q&A. I want to shift gears for a minute. John, you did allude to educating patients about their medications. I want to ask kind of a broader question, and maybe I'll throw this out to David again first. As a society or as a provider for our other panelists trying to control costs, how do we best manage the rapidly increasing cost of drugs?
The rising cost of pharmaceutical drugs is a huge challenge. I mentioned before that we've done pretty well as a Commonwealth in terms of meeting our healthcare cost growth benchmark over the last couple of years. There was 2 years where we exceeded that, and the reason was because prescription drug spending grew 13% in one year and 8% in another year, far outpacing everything else. It's been the #1 driver in terms of healthcare spending. And it's a challenge because these prices are set nationally in terms of the drug costs, and the prices are set not based on any sense of what the value that they provide, but what the market can bear and how to maximize profit. And so we have, this is a really important industry in Massachusetts. There is life-changing and life-saving innovations that are coming through the pipeline. The hepatitis C cure, biologics that are going to change the way that we think about delivering healthcare, but it comes at an incredible cost. And so I do think we need to have a serious conversation around how drugs are priced, what they're launched at, and to try to connect those prices a little bit more with the actual value that they're providing. And there are organizations that do a good job in thinking about setting kind of benchmarks or targets for drug prices. The other place that we continue to see growth is double-digit increases in prices for generics, drugs that have been on the market for decades, and all of a sudden they're having year-over-year double-digit price increases. This is a national challenge, but I do think there are things that states can do, and I hope Massachusetts will lean in on this particular area.
Mike, did you want to comment?
Yeah, gosh, we could spend a lot of time on this. This is a real area of interest in mine, and I'll just throw some figures out, just our experience on drug costs and our commercial products where we have full risk. We've had an 8 to 9% annual year-over-year increase over the last 3 years on average. Infused drugs, specialty drugs, by far the biggest driver, 12.5% annually year-over-year on average over the last 3 years. But In 17 versus 16, it went up 25%. This year, it's on course to be even higher. And what's really fascinating, 3, 4, 5 years ago, a $30,000 to $50,000 course of infused drugs was high cost. Now there's another zero on the end of that. It's gone up by an order of magnitude. So we're seeing $300,000 to $500,000 courses of infused drugs that are not uncommon. We have one patient who $1.4 million in just infused drug. Never spent a day in the hospital. It's all outpatient. It's only drug cost. So, I mean, that is, I talked about the clouds in the horizon. I mean, to have these medical inflation come roaring back, and I mean, the clouds are right over us. We're living it right now. So it is a very urgent issue. We didn't have, 10 years ago, hedge fund managers buying pharmaceutical companies in order to exploit, as you say, what the market will bear. So, I mean, the average price of insulin has doubled in 10 years, over doubled. Insulin's been around forever. So this is, I think, the single biggest driver and problem that we have to wrestle with. And the PBMs, which we could talk about too, pharmacy benefit managers, are clearly part of the problem as well. A very big middleman that's gotten very, very big. There's a reason why they were created, but they've unfortunately become part of the problem now.
I just would add, we live in to say the least, a divided political time. This is one issue that Republicans and Democrats 100% agree on. If you do any polling around trying to address pharmaceutical drugs, the public is like 80% support. Doesn't matter your political leaning or where you live or what state. People want to have, at the very minimum, a lot more transparency about the cost of these drugs. Where is the money going? It is a opaque system with all of these middlemen, and no sense in rebates that go back to the insurance company, not necessarily to these patients. It is an industry that, at the very minimum, needs a lot more transparency and sunlight.
Great.
And regulation.
Yeah.
Unfortunately.
John, did you want to say anything else about this?
I mean, from our perspective, back in our population, it's about what we can control. So I think, as I brought up, that ability to kind of put information into the hands of the patient with the provider, or even start that engagement and that conversation, for us is where we're trying to start around that. I mean, these are all very large topics, but for us, we're kind of trying to take the avenue in the sense of how can we provide education out to the patients and to the providers, provide access to phone numbers, websites, so that they can start to make that well-informed decision, and again, see how things play out around this topic.
Great. So I want to now turn back to the subject of social determinants of health, and I think Dr. Stout so nicely encapsulated many of the issues, and a number of you have touched on it. But data have shown that the medical care really only accounts for maybe 10 to 20% of the actual contributable factors to health outcomes. Social determinants probably take up a much larger portion of that. So let's talk a little bit more. I know some of you already briefly touched on this, but what are we doing here in Central Massachusetts or across the state, and what more should we be doing to address the social determinants of health? So maybe I'll start with you, John.
Sure. Yeah. One of the things I want to mention is actually a partnership that both Reliant and the ACO has around a program which we have called Community Help, which you saw in Dr. Stout is actually powered by Aunt Bertha, which allows both public and our staff to really access information around programs available across any zip code. Very user-friendly, has a great front end that allows us and allows our members or our beneficiaries to really be able to go out there and take a look at what might be out there for services that they might need. And just to kind of give you an example, I mean, why we did this is that it wasn't it was quick to see when you walked into a provider's office when a patient would leave and that provider would say to their staff, listen, this person needs transportation services, can you help out? When you looked across the desk, there was a ton of different yellow stickies, and they would go across and say, oh, transportation, there's the number, there's that person. And again, that became a challenge because, again, numbers change, services change. So now being able to provide that platform for us to serve our patients from a socioeconomic standpoint, as well as help our providers, I think has been really well received.
Great. Mike? Do you want to
Yeah,
comment?
clearly a big, big issue. I'm glad that we did spend so much time on it this morning. It's but in a fee schedule, you just can't afford some of the resources that we built in and that we really try to provide on a pay-or-blind basis. Most of our patients, by the way, are fee-for-service. Only about 35% of our patients are under global risk or risk contracts, but it allows us the ability, to be more innovative and flexible if we have downstream savings. So we have our own social workers that we connect with patients who can't afford their medications, which is unfortunately a common issue, or who have issues at home without social support. Try to get them connected with community resources. As you know, on the Fallon 365, the Medicaid ACO, we're doing a lot of that, working with connecting with community providers. And I think even the home run program is a good example of patients that have a social need that we fill. But again, it's hard to do it as a physician group practice in this mixed revenue structure. So it requires, as I think Dr. Stout indicated, really a community-wide effort and all the major stakeholders involved.
Great. David?
Yeah, obviously Dr. Stout's presentation was incredible, and the amount of energy and excitement around talking about and addressing social determinants of health has just exploded in terms of kind of the healthcare policy world in the last couple of years. And I think that's probably pretty frustrating for like the public health people who have been screaming about this for literally decades, or for community health centers who have been made this a part of their model again for decades, that all of a sudden we're like, wow, did you know that like where you live and work like matters and depends on your health outcomes? It's like this sudden like brainstorm that the healthcare community has had, but it's a good thing. And I think we're still trying to figure out, it's not so much should we address this anymore, it's how and with whom, because it has to be with that level of partnership. And I guess I would just say from the state perspective, we've been engaging in a lot of really good conversations with the Department of Public Health and the Attorney General's office, which oversees the Community Benefits Program, along with the Health Policy Commission, to say, how do we as state agencies think about aligning all of our incentives and grant dollars and funding to try to help support communities in going down this road? And so that's something that we're working on internally. Again, as you said, have to align and create those incentives across institutions and organizations. And I would also just give a shout out to Mass Health and Secretary Sutters, who successfully negotiated as part of our federal waiver for the first time, Medicaid will be able to reimburse for what's called flexible supports, which includes services around housing stability and food insecurity. And so, again, sometimes you have to pay for these things, and this is a big leap and change for the federal government, who has traditionally said, Medicaid, we just pay for medical services. They're recognizing and understanding that paying for these things matters and can have a huge difference. So a huge innovation here in Massachusetts.
Yeah, and I will say with my own experience with the Mass Health ACO initiative, I really do give credit to the state for moving the needle. This has been a real paradigm shift, and a number of you heard me allude earlier to our behavioral health and long-term services and supports community partners. One of the beauties of the ACO model is that it not only is driving closer relationships between the payers and our ACO providers, but also forming new partnerships with community-based organizations. And this really is a paradigm shift, I think, for many payers and many providers. And these relationships have grown very strong. And we're hoping that we can leverage these relationships beyond just the ACO population. So,
can I add one more thing?
Sure,
I think that's relevant to something that David had mentioned just now and even earlier. I have a slide that I borrowed from Dolores Mitchell, who was the past executive director of the GIC, which I thought was really great. It was a 10-year look at the rate of state spending and their budgets in healthcare versus all the other areas of expense categories, including public health. So public health had been cut, year over year to help fund healthcare spending, which is, some of the irony that David mentions is that, that's one of the biggest returns on investment is in public health spending. And to cut that is so short-sighted because you have bigger downstream costs, and that's a lot of what we're talking about now. But so it requires a legislative effort. Unfortunately,
Let me just jump on that too. I mean, I think, again, like I said in my opening, it was the biggest aha moment. And I think it has the greatest opportunity because it's a win-win across not only the patient, but the healthcare system, the community, and it just elevates everything. And so if we can just continue to focus on the social determinant and how we provide the resources to the patients and the people that we serve, I think it's going to be remarkable.
Great. So now moving on to the topic of data and transparency. A number of you touched on this subject as well, but I'm wondering if we could discuss in more detail what role you feel data plays in managing populations and in controlling costs. So maybe we'll start with you, Mike.
Sure. As I mentioned, we have a really robust data infrastructure. We have, by taking a global risk, we have access to claims data going back many, many years on a lot of our patient population. Claims is a very rich database. You can certainly see, kind of who your high utilizers are, but what you really want to know is, who is about to be, the emerging risk patients, if you will, because we do focus so much on treatment of end-stage disease. There's so much to be said for primary and secondary prevention. So we built in new models. We've just joined up with Optum earlier this year in April, and we just built in some of their software systems. We have 25 new predictive models that will help us, kind of get to that higher level of predictive modeling so that we can do outreach to patients, really before they get into big trouble. So that's really exciting, and we're just starting to use that and populate some of our high-risk rosters for our case managers to do outreach on. So we're excited about that, and there's so much with big data. So it's not just using claims, it's using the rich EMR database. We've been on Epic now for 10 years, so we've got a tremendous amount of information in there too, as well as some of the social determinants. So really excited to see what that brings.
Great. And John, do you want to comment on how UMass is using data to improve quality and reduce costs?
Yeah, sure. So for us, the baseline of everything that we do is data. We start with the data to be able to kind of really guide us for those interventions. And very similar, the longer you're in these programs, the more data you have. Because I think one of the pieces that you start to struggle when you first get into the programs is you don't have the trend. But once you, for us from an ACO perspective, now being in for several years where we didn't have savings and now we have savings, you start to really compare and contrast a lot of the interventions we did, and you can start to scale the ones that are really working and start to really take out the ones that are not. So across UMass, obviously being on Epic and a fully integrated record, I mean, that's really to start to come along and really help us, because again, it just enriches our database going forward. But then we also reach out beyond that and looking at other data sets, whatever we can get our hands on, whether it be census data, stress indicators across the neighborhood. That's what I talked a little bit about. Once you start to bring all those pieces together, all we start to do is provide more and more actionable information to our care management team as well as our providers that then helps us, again, to chart how do we best take care of the patient through the system. So again, data is everything, and obviously as we get more and more, we're very excited about how we can use it.
Okay. David, did you want to comment any more? You already talked a bit about transparency.
Yeah, I don't want to be the skunk at the party, but I do think it's worth reflecting that some of these electronic health systems and that have been are ungodly expensive and are maybe fueling in some cases in an increasing consolidation of our healthcare system, because for small practices and providers to be able to afford those systems is just not possible, and so may lead and feed into just the increasing movement towards employed physicians and kind of the death of the kind of independent physician that we see. But there's just not the days of kind of the family physician practice is probably numbered. Sorry for being negative.
I think you're right. If I could maybe add to that, it's not just what you mentioned, but just the myriad of different quality metrics that contractually we really need to report on. There was a report in Health Affairs by an economist a year and a half ago that showed calculated the financial burden on the average physician's practice of about $48,000 just to report on quality measures, and that was a year and a half ago. So when it was published, so that was probably 3-year-old data. But I mean, it's gotten worse. Every year there's just much more information that, you're right, it's overwhelming.
Yeah, just to kind of talk a little bit about that as well, because you bring up a great point. What's interesting for our ACO, though, is that big chunk of our ACO is not on Epic. And so we're dealing with every EHR that's out there. So again, it's really for us is how do you manage all that information. And one of the things the ACO kind of brought to light as well is by them joining with us, we kind of help them through all that regulatory piece. And we have staff to do that. And again, having worked with the independent physicians quite a bit in my career, you have to understand what they're going through in their day-to-day and not try to overwhelm it even more, but how do you put a support mechanism around that? And I think if we take that tack, then it doesn't really matter. You almost want to try to build your own health information exchange. And then at that point, you're just pulling in all the data.
That's a good approach.
Yeah, very complicated issue, and you know, certainly one factor that may be leading to some physician burnout, which is a whole other topic probably for another day. So David, since you brought up the word consolidation, that was a great lead-in to my final question before we open it up to Q&A. We're seeing a lot of cross-sector collaboration, a lot of mergers, of course, most recently the BI Leahy merger. Mike, RMG was acquired by Optum. Maybe I could start with Mike and then move over to David to talk about these mergers. Is this a good thing? Is this a bad thing? Where do you see consolidation going as we move forward? So Mike?
Well, I think that certainly there are some economies of scale in these mergers, but I mean frankly I think a lot of them are driven for other reasons. I mean contractually there's more leverage the bigger you are and the stronger your brand, and that tends to drive rates, good or bad. That's the way that it is. So. I think that is, one of the consequences of some of these mergers. I think some of them on smaller scales may come out of necessity as smaller groups are unable to really go it alone. And some of the players just aren't big enough, to get the types of rates that others are, and either have to do with less or consider merging into a bigger entity. So. A year or two ago, merge with Optum wouldn't have even occurred to me. I mean, their corporate, at least Optum Care is their provider arm of Optum Health, does have a very well-aligned corporate philosophy of, better care, lower cost, better service, which aligns very well with what has really always been our corporate philosophy. So I'm hopeful that, and I do expect that we're going to see, those outcomes improve. But as far as some of the other mergers, I do think ultimately it may not be good for the cost of care.
And I know where we were just speaking previously about data analytics. I'm aware that you've been able to benefit by some of the infrastructure that Optum's brought to RMG, including their Optum Analytics tool. So I imagine that there are other opportunities for collaboration with your parent organization and benefiting from some of the resources they bring.
It's interesting. It's such a big organization. I mean, Optum Care is a provider group. We're one of 17, I think now 18 physician groups throughout the country. It rolls up as one business line of Optum Health, of which Optum Analytics and others are business lines, which rolls up to Optum, which rolls up to United Care Group. We're kind of, one small piece in a really large machine. And I think, that real large, complex enterprise is still trying to figure out, how best, to really utilize the infrastructure and resources that they have, because they do have different lines of business. We're expecting to get a family discount in a lot of these, and some of it's been realized, and some of it we're still trying to figure out. So it's going to be interesting. But there is a lot of collaboration, which is good.
So more to come.
Yeah.
So David, are we better off with a duopoly versus a monopoly, at least in Eastern Mass?
Well, I think first starting with the premise that the business and the structure of healthcare matters on healthcare costs is something that we just have to accept that it does. And I think in a really positive innovation here in Massachusetts as part of the law that set up the Health Policy Commission, we are tracking and looking and creating much more transparency about what the impacts of these consolidations may be. And this is a national trend. This is not just Massachusetts. Nationally, this is happening everywhere. But here, at the very least, we have a lot more data and information and public scrutiny about, are these things really in the public interest, and how can we, as a state, through the Attorney General's office, with the Department of Public Health, through the Health Policy Commission, try to set some parameters around these consolidations so that we really maximize some of the potentially good benefits that can come from this in terms of efficiencies, in terms of, in the case of this particular, the Beth Israel Leahy merger, a potential competitor to our high-priced market leader and partners, and minimize what we know are some of the really negative impacts that come from these mergers. The academic literature is unequivocal on this point. Hospital mergers increase prices and reduce quality. So how do we, as a state, try to flip that on its head? And in this particular case of this merger, the Attorney General and the Department of Public Health have put a sweeping range of conditions and enforceable commitments as that moves forward. And so this will be, in many cases, I think, a true test to see if that approach can work in terms of mitigating some of the potential downsides from these things. I would just say also, I do think this trend will continue. And I do think, there's a lot of other interesting market innovations that are coming down the pipeline, between the CVS and Aetna merger, to kind of this, what Amazon is going to be doing, and Atul Gawande. So there is going to be, I think, a potential to really kind of shake up and change how we think about delivering care in the future that maybe look very different than these kind of hospital merger-based transactions that we've seen today.
Well, certainly if there's one constant in healthcare, it's change. So interesting times lie ahead. So I wanted to set some time aside for questions from the audience. Don't be shy. I do have more questions.
So we've talked about what, the payers can do, what the hospitals can do, the doctors can do. How do you get the patient engaged in their own health care?
That's a great question. I think from us, from an ACO, that's one of the items that we're looking to tackle going forward, is how do we get the beneficiaries, how do we help them understand what an ACO is, and what it means to them, and how it might change their care or help navigate them. And so we're kind of really looking at what that opportunity might be. And so we've come up with a couple of different ideas that we're kind of really thinking about, whether that be talking at senior centers or different venues, to be able to kind of really just talk high level. Like what is an ACO? What are we? What are we trying to do? What are we trying to provide? I think our first real test in that is really around this prescription, because we really saw a really big gap in that. And it was really not just so much how we're talking with the beneficiary, but how can we get the beneficiary and the provider to talk together around that. So more to come, but that's certainly where we're kind of looking for the future, is how do we educate the patient.
Big challenge in our group. We have care managers that do a lot of outreach. We are building up a behavioral health department that is really going to do a lot more of this, I think, more effectively. There's some interesting vendors out there in this space. I mean, there are thousands of them. There's a lot of venture capital that's been dumped into healthcare, since the recession and the recovery, I should say. And there's one in particular that we've interviewed that I think is pretty interesting. They use the term psychographics, where they psychologically profile a population, a patient base, based on some big data that's available through places like Experian and Equifax, and can purchase it apparently, and or use their own questionnaire, which is very short, and segment the population into 5 different categories. And I've actually found that by prescripting what they say and how they do outreach, whether it's texting or phone call, based on the segment of that population and their psychological profile, have shown markedly improved outcomes and engagement. So that's very interesting, and we're actually, I think, going to hire them to help us out. They've got some really exciting data. By the way, that comes from the retail industry. Procter & Gamble pioneered, no surprise, I guess.
We have another question right here. Oh, okay.
Hi. This is a question for David Seltz. So we just talked about patient engagement. We've talked a lot about provider engagement. And I'd like to talk about regulatory engagement, because while there is an inordinate amount of regulations coming out, at least at the federal level, regarding healthcare and what providers need to do. By your own account, providers are getting really frustrated with trying to keep up with the regulations and to report what's being asked of them to report, and to have the equipment and the software and infrastructure needed to do that. So where do you see healthcare from a regulator's perspective? Where can the regulatory environment or the legislators make inroads here, whether it's providing the Mass Highway or some infrastructure so that those independent docs can stay independent and stay in practice and take care of their patients and not spend their time reporting?
So we, every year we hold an annual hearing, a 2-day hearing, where we kind of take the pulse of what's going on in healthcare. And this year we had a great speaker, Ashish Jha, who's written about why does healthcare cost so much more in the United States than in these other countries. And really, you know, one of his findings was, one, the price that we pay for goods and services is just much more here. But the other is this incredible administrative complexity that we've built up. And that is driving a cost structure in our provider systems, and not just a cost structure that's increasing, but frustration and burnout and all of these things. So I think in a really good, positive way, this was a huge theme that kind of came out of these hearings. And I think from the Health Policy Commission standpoint, we're going to make this a major theme for 2019 and really pull together a lot of different people to say, what can we do in this state at the very least to try to deal with all of this administrative waste that provides no patient value? And I'll give one very specific example of this. So was mentioned earlier, just in terms of quality measure reporting, we looked at the major health plans in Massachusetts, and there was 160 different quality measures that like the top 4 or 5 health plans were requiring of providers. Each one of them a completely different set of quality measures. In some cases, they would have a same quality measure, but they would measure it a little bit differently, track it a little bit differently, and providers are going insane doing all of this. And so we spent, with Executive Office of Health and Human Services, 2 years bringing together providers, bringing together the health plans to try to say, can we have a more limited set of quality measures that we can all agree on, that are meaningful and impactful? And we did, and we got that down to a set of less than 30 quality measures that everyone said, okay, we're going to put these in our contracts because these are the ones that really matter. And from the provider standpoint, be able to say, okay, now I know what to focus on. Now I can actually do better on some of these measures because it's not just I'm reporting on 100 different things to Blue Cross, to Fallon, to Health New England, to Harvard Pilgrim. And so that is, I think, a really good effort. Unfortunately, some of the health plans are saying, well, we're not sure that we actually want to take this new quality set. Maybe we'll do it in 2020, maybe we'll do it in 2021. And so we do have to continue to push these market participants to say, if we're going to agree on alignment, how do we actually then put those into contracts and make that real, and not just have this be, you know, an agreement that doesn't actually result in any positive outcome. So good work to get to this stage, but we do need to continue to push. And there may be a role for the legislature in statute to put some of these things in place.
Great. So we have time for one more question.
I wanted to, first of all, say amen to trying to reduce the insanity around understanding quality and administrative burden on providers. But I wanted to bring it back to patient engagement for a bit. So at Reliant Medical Group, we have a patient advisory council, and we try from time to talk to them about the cost of care. And really what we hear all the time is there's this real lack of transparency around the cost of care. I don't think anybody, payers, providers, regulators, anybody has really been able to kind of open that black box. So in terms of engaging patients on the cost of care and what they can do to understand and be part of the solution, since we've all agreed that it's not one stakeholder that can solve this problem, what can we do to kind of take the pricing of healthcare and the cost of healthcare out of this black box, and why can't we get our arms around that?
Great question. That's a really great question. Even though it's legislated in part of Massachusetts healthcare reform that there's, you know, we need to have price transparency, it's really hard to do. And I think just a level set, it's probably worth a minute or so to talk about current state and why it's so hard to do. You know, different vendors in the healthcare space contract with different payers or the same payer at different rates, which makes it difficult to know. what you're going to pay. And vendors will charge. What they charge is not necessarily what the actual claim pays at. It adjudicates at the contractual agreed upon rate between the vendor and the payer. So in the commercial space, you've got different rates for the same procedure or the same E&M code, depending on which vendor, hospital you go to, or which, even if you're under the same payer and the same benefit structure. And to compound that, there's the high deductibles, there's the co-payments. So we, as a provider group, can't really tell a patient what they're going to wind up paying, even for something that we offer for a service. We can tell them what we charge, and what makes it more complicated is, we have a charge master where we charge 250%, or at least we used to, 250% of Medicare rates for everything. And the reason for that, but we don't get paid that. We get paid, it's always less than that. It's whatever the contractual rate is between Blue Cross and us. But we charge at a rate that's higher than what our best payer pays, so that you kind of don't leave any money on the table. But that doesn't tell you what you're going to pay. That's actually an inflated rate. And we see that even on a grander scale with some other vendors, some of the hospital systems. So that's really largely what makes it so difficult. And I think it's that complexity on the retail pharmacy space that drove the rise of the pharmacy benefit managers to fill that, that complexity. That's another story, I guess, but that's what makes it so difficult. Just trying to kind of summarize a little bit about current state.
And I would just add to that, the state does actually now have a website where it's called Compare Care, where you can go online and look up different services and see kind of the average payment, rates, the actual rates paid for some of these different things. But for a consumer, it's not necessarily that useful. You get a good sense of maybe some of these big differences, but it's not reflective of what you're going to pay based on your copay or your deductible and your health plan. And that's really the actionable thing that patients want to have. And compounding that confusion is still a perception sometimes that more expensive equals better. And if my deductible is $1,000 or $2,000 and I'm looking at a $10,000 procedure, do I really care? I mean, I'm going to spend my $2,000 anyways, and if this place is $30,000, it's just my insurance company who's paying that. And I've been paying my premiums for the last 3 years, and this is my time to get healthcare services. So this $30,000 hospital must be better quality than this $15,000 hospital, and that is absolutely not the case. So, transparency around prices is great, but it has to be paired with quality information that is actionable for consumers, or else it'll lead to not great decision making.
Yeah, so David's point to go, and I'll just make a quick point. I think, for most, they're very concerned with what their copays and their deductibles are because somebody else is footing the other side of that bill. So, they're just focused on what they have to pay. But the other piece is that same patient that's coming in, a lot of them don't even know what the benefit they have. They don't know the copay. So I think the transparency is not just with, what we've talked about here, but it's also people knowing and making sure they know what their benefits are and what their structure is. So I think it's kind of it's a little bit of both.
So obviously our healthcare system is not without its challenges, but I will tell you, when I was at Mass Health, I had an opportunity to travel around the country, meet my counterparts from other states, and it really reminded me how fortunate we are to be in a state such as Massachusetts, where we really have skilled, very innovative regulators. We have providers who are very committed to the patients they serve, as well as payers who are very connected to the communities and keeping these communities healthy. Despite the long road we still have ahead, I am very encouraged by much of what I've heard today, and I hope you are as well. More effective use of data analytics, forging stronger partnerships with sectors with whom we previously did not collaborate, and really addressing many of these other issues outside of medical factors, particularly the social determinants of health, to really improve the quality of care and reduce health disparities. So I hope you'll join me in thanking our panelists, and really just an outstanding presentation. Probably left more questions open than we had opportunity to address, but really very, very helpful. Thank you so much.
So I just have less than a minute of wrap-up comments. I just wanted to ask a question first to Michael. There's a pen, there's a Reliant pen, and I was wondering, is this one of those modern digital devices? There's a little stethoscope on it. Is this keeping pulse and blood pressure when we put it in our pocket, or is it just a pen?
I wish I could say it was, but it's just a pen.
It's just a pen. Okay. Thing number two, when we spoke with David on the phone before coming to this, his PR shot has this wonderful bow tie. I said, geez, David, are you going to wear your bow tie? And he wasn't sure. I said, well, if you wear your bow tie, I'll wear mine. But he didn't warn me, and if you can see them, that he had those beautiful matching red socks. So, wonderful haberdash. I'm glad the speaker's tag was also red, so we didn't throw your color system off. But anyways, a wonderful conversation. Thank you so much. We want to thank our presenting sponsors, Fallon Health, Reliant Medical Group, and the UMass Memorial Healthcare for their sponsorship, our corporate sponsor, National Grid, and our exhibitors, the Language Bank, a member of Essentia Care Alliance, Mass Health Connector, Pfizer Vaccines, and special thanks to our host, the Beechwood Hotel, Curry Printing, Elevation Exhibits, Ron Brule Photography, Ron's right over here, and Through the Years Productions. Just one note, one of the benefits of coming here is we will send you a video clip of this conversation if you've got associates, and so I wish they were here for this. And in addition to that, we're going to make available to attendees the slides from Soma's presentation if some of those data points look like something you want to hold on to. So that will be forthcoming, Chris, in the next few days to everybody who attended. So thank you all again for being here, and thanks again for a great conversation.